mixed with blood, there will probably not be enough time to smear everything before clotting occurs. Therefore, it is important to pick the most promising material first and make at least 1 or 2 good smears. If the material has already clotted, one may make a few smears and fix them in alcohol for better translucency than air drying. A cell button may also prove productive. Then repeat the thin needle aspiration biopsy, if possible, in a different part of the target where bleeding and clotting has hopefully not already occurred. Fragments of tissue can be concentrated for smearing in a second way by first tilting the slide slightly toward the frosted end. Then use a clean slide to sweep all the material toward the frosted end, and without lifting the slide or changing the angle, move the top slide to the middle of the bottom slide. Lift the top slide straight up. This will result in a concentration of fragments across the bottom slide right here. At this point, the tilt of the bottom slide is increased to get rid of as much of the fluid as possible, and then a smear is made using the basic technique described above. Take care to limit the smearing to the stranded fragments. If the smearing includes the material at the frosted end of the slide, fluid will be mixed back in and dilute the specimen. Also, make sure that the bottom slide is tilted toward the frosted end throughout the whole procedure, or the fluid will run back over the valuable fragments. Sometimes a few fragments will stick to the short edge of the top slide. In that case, they may be smeared in this fashion. In addition, a few fragments may be left behind close to the frosted end of the slide. If this happens, go ahead first and smear the properly collected fragments. Then, with a short edge of the smearing slide, sweep off the stragglers and smear them in this fashion on a fresh slide. A gauze pad can be used to absorb fluid by holding it up against a tilted slide. As soon as most of the fluid is absorbed, the material may be smeared. I have shown the basic sampling and smearing techniques. Now I will show them again, slowly and without interruption. Now I will run through the same techniques at the speed required in the real situation in order to avoid clotting and air drying. Now let's move on and do a thin needle aspiration biopsy on an actual patient. I start with careful palpation and estimation of the size of the mass and the depth under the skin. I then place my fingers on top of the mass, spread them, and hold the mass firmly. The skin between my fingers is cleansed with a simple alcohol swab. Now, without moving my fingers, holding the target, I pick up the instrument and get in position. I support the syringe with my thumb like this. Another possibility is to simply lean the syringe on my forefinger. The needle will enter the skin at an angle. Because of this, I will penetrate the skin a little below the mass so that the needle tip is heading straight for the center of it. I'm now in a good position to go ahead with the sampling and will move right along. This sample consisted of a small semi-solid droplet that lent itself very well to division and the basic smearing technique. One slide was fixed in 95% ethyl alcohol and the other one was left on the table to air dry. Make sure the smear is completely dry before putting it into any type of container. If it is put in wet, there will be artifact due to slow drying. Leaving the lid of the container open does not alleviate this problem. I always do a second sample of any one target in order to ensure enough material and also to sample more than one area in a large target. The second sample is more likely to contain blood than the first one. This is because of the trauma of the first sampling. In this case, the second sample contains a fair amount of blood. Here, I use a combination of the first two concentration techniques described earlier. On occasion, I will perform a third thin needle aspiration of a given target. The reasons for doing that would be either to sample a large target widely or to try to improve on an apparently scanty harvest from the first two attempts. In my experience, the first thin needle aspiration of a given area is the best opportunity for a good sample. With each subsequent try, the amount of blood is likely to increase. Therefore, to sample one small area more than 3 times is rarely productive. It may be better to ask the patient to come back after 1 to 2 weeks for an additional sampling or to do an open biopsy. When sampling deep, non-palpable lesions, visualized by radiologic image or by ultrasound, I suggest a slightly different approach. After the skin has been cleansed thoroughly, the area is draped with sterile towels. Sterile gloves are used so that both hands can be used to guide the very pliable needle as it travels through the tissue. Now it is time to check the position of the needle. The needle needs to be placed well within the target and in a position so that when the needle is moved back and forth, it will stay inside the target. If the needle is shown barely within the target, and especially if it is placed in a close to tangential position, the yield is likely to be poor. Once the needle is confirmed in a good position, the stylet is removed and the syringe is attached. A syringe holder is usually not needed. Instead, the syringe may be held like this. In this position, the plunger can be easily pulled back and held in place during the sampling. Remember that a small amount of suction is enough. With the suction in place, the attention can now be turned to collecting the sample by moving the needle back and forth. The length of the needle excursions should be tailored to the size of the lesion. In other words, when sampling a small target, Make short excursions in order to stay inside the target. In a larger lesion, longer excursions are usually more effective. If the lesion is suspended in pliable tissue, such as lung, the excursions may need to be longer in order to compensate for the target moving up and down with the needle. It is crucial that the needle tip is truly moving through the target. Rotating the needle does not appear to improve the harvest. After the sample has been collected, the suction is released without delay. The needle with attached syringe is pulled out and immediately handed over for preparation of smears. Time here is of the essence. Therefore, the person who is going to prepare the material should be standing right next to the operator during the procedure. Reach for the sample and have the workstation ready with all the equipment within a few steps. A new needle should be used for each additional sample in order to facilitate expulsion of the harvest and to avoid introducing already clotting blood into the subsequent samples. After each sampling, a portion of the material is evaluated for adequacy. The main requirements are that the stain is fast and easy to apply, and also that it provide enough detail to allow the microscopist to decide if the material is diagnostic. Toluidine blue is my preferred stain, mainly because of its speed. Other commonly used stains are quick versions of hematoxylin and eosin, Papa-Nicolau, and May-Grunwald Giemsa. Diff-Quick can also be used. Toluidine blue is very easy to use. After fixing the slide in 95% ethanol for about 1 minute, the slide is retrieved and placed on absorbent paper. 1 or 2 drops of the stain is placed on the smear and a cover slip is placed on top. I let the stain penetrate for about 15 seconds before removing excess stain by turning the slide and pressing gently. After wiping the bottom dry, the sample is ready for examination. After evaluation, the slide is returned to the alcohol container. The cover slip will fall off and the stain dissolve. The slide will be restained with Papa-Nicolau for final evaluation. Some anatomical sites carry special challenges, and the thyroid gland is certainly one of them. Several factors are important for success. The first one is the position of the patient. Hyperextension of the neck created by a pillow under the neck and shoulder area usually makes it more difficult to access the mass. This is because both the skin and the muscles become stretched and firm, hiding any deep-seated nodule in the neck. In my experience, it is easier to hold and palpate a nodule when the neck is relaxed. This can be achieved by laying the patient down flat or by putting a pillow under the patient's head. The second is stabilizing the nodule. Most nodules will be adjacent to the trachea, and the trachea therefore can be used as a support. The easiest way to hold the nodule is to use the fore and middle fingers on each side of the nodule, pressing against the trachea. If the nodule is large and extends laterally, make sure it is not covered by muscle. In order to push the lateral muscle aside, place the fingers medial. The third factor is the angle of the needle. In order to avoid passing through muscle and into the trachea, the needle should be tangential to the side of the trachea. The main reason the thyroid gland is a tricky area is its many blood vessels. The harvest will almost always contain a fair amount of blood. Therefore, I recommend doing fewer excursions with a needle, somewhere between 5 and 10. Do remember, though, that suction alone will not produce a good sample. The needle technique without suction, described earlier, often works well in the thyroid gland. Targets in the axilla may be difficult to reach and to immobilize. The best position for the patient is to be sitting up with the arms slightly abducted and as relaxed as possible. One way of accomplishing this is to put the patient's hand on the operator's shoulder like this. Another possibility is to have an assistant support the patient's arm in the same position. With the patient in this position, it is possible to reach and sample most masses in the axilla. The mass is localized and then trapped against the chest wall with the fore and middle fingers. The thumb of the same hand is used to stretch and flatten the skin below the target to ease access for the needle. Access is made easier by having the operator sitting at the slightly lower level than the patient. It is important that the patient does not move away during the procedure. This can be prevented by giving the patient support in the upper back area. Another challenge is represented by masses under the sternocleidomastoid muscle. These may be large, causing the muscle to bulge, or small and difficult to detect under the muscle. In both cases, it is wise to avoid penetrating the muscle in order to sample the mass. Instead, the lump should be held by grabbing around the muscle, allowing the fingers to support it in the back, and the thumb to palpate it directly through the skin in front. Then, without loosening the grip, the thumb is allowed to slide down slightly, stretching the skin over the target. The skin is cleansed, and the needle is entered for sampling.